Welcome to the HQI Stopping Sepsis and Long-Term Care conference call. My name is Sherry, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. So now I'd like to turn the call over to Candy Hamner. Candy, you may begin.
Thank you. Good afternoon and welcome to everyone attending the webinar today. My name is Candy Hamner. I'm one of the improvement consultants with HQI, which is Health Quality Innovators. We used to be known as VHQC. And we want to invite you today to attend the webinar on identifying, stratifying, and communicating sepsis in long-term care. This webinar was prepared in response to several requests from our nursing home participants in Maryland's Stopping Sepsis and Long-Term Care project. We are entering our year 2. We also recognize that many Virginia nursing homes have signed up for this webinar and are considering signing up for the Stopping Sepsis in Virginia hospitals and nursing home project. We hope this webinar will provide you some insight into the quality of the educational programming you can expect from HQI. If a Virginia nursing home wants more information, we are sending out a fact sheet and an invite to an informational webinar scheduled for Tuesday, October 25th from 11 a.m. to noon. I'd like to introduce you now to the long-term care team at HQI and draw your attention to, in the middle, Deb Smith, one of our improvement consultants. She is the contact for the Virginia Sepsis Program, and any Virginia facilities that would like to contact her for contact information is here. Also, Sheila McLean is the Programs Director over both Maryland and Virginia Long-Term Care projects. Our faculty today, we are proud to announce that we have Susan Levy, MD, CMD, President of AMDA, and she is now on the faculty of HQI. I will be introducing her a little later after I go through some housekeeping. I'd also like to remind everyone about our partners, the Maryland Hospital Association and the Maryland Patient Safety Center, two facilities who have supported us in the Stopping Sepsis and Long-Term Care project in Maryland over the last year and are supporting us again as we enter year 2. I'd also like to talk just a second about HQI. We are a private, nonprofit healthcare consulting firm. Been Virginia's QIO since 1984 and now have both Maryland and Virginia. And we have an experienced team of quality improvement professionals that can help you with all kinds of projects. And as you see, there is our web access right there. So why sepsis? Why does it matter? And many of you in Maryland have seen this slide before. We talk about 1 million patients who are diagnosed annually with sepsis. And up to 50% of those people will die. We know sepsis is a leading cause of hospital admissions from nursing homes, and it's actually one of the top causes of readmission. But I want to have us hit home a little bit and give you some information from calendar year 2015 for both Maryland and Virginia, so you can see how deep sepsis runs and how important it is to make a change. Look at the numbers, and they almost parallel each other. 2,938 residents were admitted from long-term care to acute hospitals with sepsis as present on admission in Maryland. 1 out of every 4 or 5 of them, 4 to 5, actually 4.6, died. Another 404 died within 30 days of leaving the hospital. And what that means is 1 out of every 2 to 3 admissions for sepsis from a nursing home to a hospital die within the hospital or within 30 days of discharge. Look at the Virginia numbers, almost the same. 1 out of every 4 or 5 died during the hospital stay. Another 683 within 30 days of leaving the hospital. And the same number down here, 1 out of every 2 to 3 admissions. I don't think these numbers are Maryland and Virginia specific. I think you see these kinds of numbers across the country. But what it does say to us is, this is why this is so important. Now I'm going to introduce to you Dr. Susan Levy. She has been a director for over 25 years, currently the president of AMDA, the Society for Post-Acute and Long-Term Care Medicine. She is a medical director in Delaware and does additional consulting work for post-acute and long-term care. She's a graduate of the University of Maryland School of Medicine, completed her internal medicine training at the Medical University of South Carolina in Charleston, and her fellowship in geriatric medicine in Mount Sinai Medical Center in New York. She's board certified in internal medicine, geriatric medicine, and hospice and palliative care. She's been a certified medical director since 1996, and we are extremely happy and privileged to have her on site.
There appears to be an issue with the audio. Can you move closer to the phone? At this time, we're not hearing any presenter. Looks like our presenter line has dropped. I will reach out to them. Please stand by. And then we have our speakers back on.
All right, thank you, and I appreciate you all bearing with us. I'm not sure where we left on the slides, but I think we're fine starting here with the definition of sepsis, which I think most of us are pretty comfortable with at this point in time. Can you advance the slide for me, please, because it's not advancing when you reconnected it? Are you there? Did you lose them again?
I still hear you. Emily, are you still on the line?
Yes, I'm here.
Can someone do the slide for us, please?
I'm sorry, Sandy's still on the line.
We have the control? Yes, okay. So anyway, the basic pathophysiology of sepsis. I think, again, most of you are familiar with why we're so concerned here is you have a bacterial pathogen. In the case of sepsis, you have this almost, if you will, abnormal response that exceeds the boundaries of what we need to manage an infection and creates this whole sepsis syndrome that results in such morbidity and mortality. Okay. So what about sepsis and aging? And this is true for infections and aging. It's that we know that as we get older, and certainly in the over 65 population, there's a higher incidence. When an infection occurs or when sepsis develops, it's usually at a higher severity when they present, and mortality is greater. In addition, one of the things we often don't talk about is the functional impact that having a bout of sepsis can have, and the, if you will, the post-illness morbidity that occurs for individuals in terms of their functional status. And certainly from an acute stay can be why also many residents need lengthier post-acute stays following a bout of sepsis. Major sources in this setting and in this age population are obviously urine, pulmonary, skin and soft tissue, and GI. We know in terms of mortality that it's typically your pulmonary and GI infections that tend to have a higher mortality. So what else do we know about sepsis in nursing home residents? And this is a study from Journal of Critical Care back in 2013, looking at almost 20,000 emergency room visits and trying to stratify differences between where patients came from. And obviously recognizes sevenfold increase in the diagnosis of severe sepsis for nursing home residents versus non-home nursing home residents. The fact that nursing home residents more typically staying by admitted to ICU, their length of stay was longer, their mortality rate was often higher, and again, the comments about respiratory and GU in this case being the most common sources of infection in this study. So what about the risk factors? And again, they seem to be the typical list of risk factors for many things as we age. But I think it's important to focus on the fact that, frequently individuals at this age develop a frailty syndrome, which puts them at higher risk for many things, including infection and sepsis. Some of the medications that we use, like steroids, put people at higher risk. Instrumentation, Even just repeated hospitalizations further put people at higher risk and at risk for exposure to drug-resistant organisms. And again, we look at things like normal aging. And you hear a lot of talk about immune senescence related to the various ways that our immune response works. But probably even more important is changes in host defense mechanisms. As we age, there may be changes in gastric acidity. As we age, there may be changes in what's called mucociliary clearance in our lungs, which then puts us at higher risk when we aspirate of actually developing a frank pneumonia. Our skin loses elasticity and is at higher risk for injury, and therefore when injured, it's higher risk for developing infection. Although when we talk about the post-acute continuum, there's many different settings outside of the hospital that we're referring to. Most of what we're going to be talking about today really applies to the nursing home setting, although there can be overlap to these other post-acute settings of care. We know that probably over 8 million people are served in our post-acute setting every year, many of which are in-home care, but many of which are in various different levels of care, and certainly nursing homes. So what about nursing homes? There's over 15,000 nursing homes in this country with 1.4 million beds, and probably 4 to 5 million people actually are in nursing homes over the course of the year. So many patients were touched by a nursing home stay, and therefore these risks. We know that there's some differences between those who are there for short-stay rehab versus long-stay, and we know that one of the increasing populations of nursing homes are younger patients who have some, whether it's brain injury or other serious neurologic conditions that resulted in their need for shorter long-term nursing home stay. So the barriers to recognition, I think, are pretty obvious to many of us. Many of the symptoms that reflect infection can also occur with other illnesses. And so we've got to use our skills, really, as clinicians to be able to tease out when infection is present or when these signs and symptoms are from other causes. Not all fever is infectious in origin. There are many causes of confusion and mental status. Respiratory rate can be elevated because of anxiety. So important that we realize that although we want to be concerned about infection, that we really make sure we broaden our differential diagnosis and don't overdiagnose infection or when something that's not the case. And we have other limits. Our access to diagnostic testing and turnaround time is a lot less than it is in acute care hospitals or emergency rooms. Many of our patients have been in hospitals and therefore they're colonized with typically drug-resistant organisms. And so that, frankly, although we talk about the 48-hour time frame, we know that most of our, in terms of nosocomial infection, we know that most of us get infected by organisms with which we are colonized. And so if we pick those up in acute care hospital, certainly if it's an infection, odds are it can be with a more drug-resistant organism. We know that we have problems with staff education and training, the early recognition, and we'll be talking later about some of the tools for that. Lack of on-site practitioners, although I think that that's beginning to improve as we're seeing more and more facilities have nurse practitioners, TAs, and physicians on site on a more regular basis. And we'll talk a little bit about advanced care planning, which I think is often critical. And why is that important? Because many of us learned early on in our training those words OSPR, which pneumonia basically, in summer pneumonia can be the old man's best friend. So usually we die from something, and it's not uncommon that infection or sepsis is a terminal event at the end of life. And it's important that repeatedly treating patients for bouts of infection, we often need to recognize that this indeed is someone who needs end-of-life care and palliative care, and we need to have those discussions earlier with our patients and certainly with their families if they're unable to make those decisions. We also know that those repeated courses of antibiotics does nothing often to increase longevity or quality of life, but only manages to create the superbug issues that we have. In Maryland, and I know that Virginia, I'm not as familiar maybe with their forms, but in Maryland we have the mulch form. And actually, also, we don't look at the back of the mulch form, but if you do, there are specific questions relating to hospital transfer and medical workup and the use of antibiotics for presumptive infection. And I think that sometimes we need to actually look at the back of the form and not just stop with the CPR issues, but really look at some of the other care issues, particularly when these arise. So we have guidance from our patients or families on what they want to have done. Medicare certainly recognizes it's important for us to have these discussions, and in fact, they put their money where their mouth is, in terms of wanting us to have advanced care planning. For a long time, we've all been required to offer the ability to fill out advanced directives to patients whenever they come into hospitals or nursing homes. But now they basically say that they will pay practitioners to have these conversations with patients. And these are a little bit of the details. There's actually 2 billing codes that are available. If the practitioner in your facility happen to be unaware of these, we should educate them in these. So certainly these are additional opportunities for them to be able to have a conversation with their patients. And we're also working to talk more about what the structure of that conversation would be. Although really CMS has not put a whole lot of limits on, unlike they do for many billing codes, has not put a lot of requirements on these billing codes. So some of the key interventions, I kind of looked at a lot of the interventions that are really around prevention, which is infection prevention. The key things we know, we're now in flu season, so immunization is critical. Hand washing, all the things that we need to do to prevent infection, particularly delining, and also in some cases deprescribing. Getting patients off those steroids, getting them tapered. Also the use of early recognition tools and triggers, and again we'll be talking a little more about that later. Early empiric therapy when there is a risk is high and when we're concerned that a patient may have an infection, that we need to get treatment started quickly. And that means that we need to have access to oral sterile antibiotics quickly. And of course we need to do this though all in keeping with principles of good antibiotic stewardship. I think on fire lectures you maybe are familiar with the Q-Sophitol tool, which works very nicely in this post-acute setting where I don't have things like serum lactate and all sorts of rapid blood test results available to me to help me identify or think about whether this patient may have sepsis. So the Q-Sophitol was basically developed for patients outside of the ICU so that this could be done very quickly to help people recognize that we may have sepsis. And I actually borrowed this slide from one of my colleagues, but I think it really is fairly simple. It's hypotension, autosomal status, and tachypnea. And if you have two or three of these things, you really should be thinking about could this patient be septic. I think the most difficult in this setting is often the discussions around mental status. And I do think we need to do a much better job about communicating, determining what someone's baseline mental status is, and communicating change in mental status, particularly as patients transition from one level of care to another. It's too often that the patient comes into the nursing home and the first evening they develop confusion and you're not clear as to whether that's new or old, it's at their baseline. If you have the information, sometimes you will be drilling down and you'll find somewhere in the nurse's notes that they had indeed triggered positive for those hand tools in a nursing home, in a hospital, and that information wasn't necessarily shared. So it's important that we really look very carefully at the different tools we know. Some are not very good. This tool, which tends to be used in nursing homes, and as part of the MDS, is a very crude measure of cognition. The hand tool is good particularly for delirium, which is often what we're concerned about, with the change in mental status in patients with infection. And certainly patients in the nursing home are dealing with delirium on top of dementia when there's an infection. We really need to use our good clinical skills and make sure our good assessment skills and make a determination if there's been a change. And we're going to make sure we do those handoffs well, allowing each other to talk to each other when we have particularly difficult patients. So what about early recognition? When to hold them and when to move them out quickly. Most people will tell you if the care directive or for aggressive care, if I suspect someone is septic, management in nursing home is probably not appropriate. These are patients that really will benefit from critical care services, and I think there's data that's starting to support that. That doesn't mean in someone who's developing an infection or maybe developing a serious infection, the quick response may not keep that patient from developing chronic sepsis, and I think that's the key in our setting. We should practice responses to acute change in condition so that we're quick, that we're rapid. We know who's in charge. We know who's supposed to get the supplies. We get the lab worked out quickly that we need to. We get the antibiotics started quickly. We need to practice and not just kind of do business as usual. So we can move rapidly to avoid the patient's conditions from deteriorating where they do require transfer out. Lots of initiatives we're having to deal with in this setting. They sometimes seem almost conflicting. It's like, you want me to decrease readmissions, but then you're telling me I should be moving sepsis patients out to the hospital. You want me to reduce sepsis, but it also, to do that requires that I treat early and often empirically when somebody is very sick, but then you're concerned about antibiotic stewardship. And in reality, many of these initiatives actually overlap and actually do complement each other. And we need to think about that and be working on all of these strategies together and see how they do overlap. So just talking about the readmissions issue, absolutely no question. This is a study, I think, based on admissions in 2011 of patients who were hospitalized from nursing homes. Sepsis, pneumonia, urinary tract infections, aspiration pneumonia, all major reasons for patients who are in nursing homes to get hospitalized. So very clearly that sepsis as well as other serious infections are really key in our management of the readmission issue. The cost is there also, lots of money, both for sepsis there and pneumonia as your first two, That's all, because remember, sepsis patients are very expensive patients. They're often going to require ICU settings, and as we've already talked about, length of stay for nursing home residents are typically longer because there are multiple comorbidities. We also know about readmissions, and I think this is from Jank's work, which links into this, begins to link into this whole issue, if you will, almost post-hospital syndrome. If we look at the common reasons we're all looking at readmissions, heart failure, pneumonia, COPD, and some of the GI disorders, the reasons the patient comes back to the hospital in that first 30 days often is unrelated to the initial index admission diagnosis. And frequently, that two-thirds there, basically, what we're dealing with, of patients coming back after one of those index admission diagnoses, and two-thirds of cases are coming back for another reason. And very commonly, that reason is an infection or sepsis. So again, clearly to address readmissions, we've got to be dealing with this issue. I talked a little about post-hospital syndrome because that is, and what are they coming back with? And we are beginning to recognize that something happens to you as a result of an acute illness that puts you at higher risk for other things going wrong. There's concerns about whether this is related to sleep issues, nutritional issues, unresolved pain, the emotional stress of the acute hospitalization, the basic deconditioning, the multiple medications that are used, and the changes in medications. But certainly recognizing that something happens to you as a result of an acute care stay that puts you at higher risk of having more bad things happen to you. In geriatrics, we often talk about the cascades and the downhill cascade. We talked a little bit about antibiotic stewardship, certainly a major initiative. We know that there are many patients, as we've talked about, admitted to nursing homes in this country every year. We know that from the CDC data, and this is actually taken from the CDC website, that up to 70% of nursing home residents receive an antibiotic during the course of the year. And so in some cases, up to 75% of that, I believe we're starting to improve that, but up to 75% of those courses of antibiotics are incorrect. That doesn't mean that the person didn't need an antibiotic. It just means either the wrong antibiotic was chosen also, too long or too short, and it may actually have just been prescribed incorrectly. And so most of you should become familiar, if you're not already, with the core elements that CDC has put out there for your antibiotic stewardship program. In fact, with the new rules of participation, which I mentioned briefly, antibiotic stewardship is very key for nursing home facilities. Again, with stewardship, as with many of these initiatives, it all starts at the top. So we need to make sure that our administrators, those who might work in change, that those who are in change leadership, really recognize the importance of this initiative in providing better care for our patients, but also in, preventing hospitalizations by doing basically the right thing and only using antibiotics when they're absolutely necessary. And of course, we know that the antibiotic stewardship issue links very closely into concerns about C. difficile infections. So I know their initiative with QIOs have also had around that. But, C. difficile really doesn't tend to be as much a problem if we haven't had it linked to antibiotic usage. Transmission is important. The person has to get colonized. But it's the use of antibiotics that seems to actually trigger, if you will, the C. diff problems that actually occur. So again, a linkage between stewardship and C. diff potentially being a cause or creating a cause of sepsis. So again, these all do link together. Now I'm a medical director, and I also practice in nursing homes. So what should your medical directors be doing? And I think this is an issue where more and more we're realizing that your physicians and your practitioners really need to be aligned with your initiative. And certainly it's one of the reasons why I'm very pleased to be working with HQI at this point, because of your commitment to see that we do bring in medical directors and practitioners. So the medical director, one of their key roles is overseeing policy and procedures. So working with you around things like rapid response, what's happening with your antibiotic stewardship program, but what also with antibiotics are in-house, what should be done, how timely. They're also responsible for overseeing the medical staff and their practice patterns. Are they responding appropriately when they're called? And they should be a clinical champion for your quality efforts, particularly those that relate to physician performance. But in all cases, should really be an active participant in your quality program. And in terms of the practitioners, we know that there are many, more and more nurse practitioners and physician assistants in nursing homes these days. And we need to be concerned about site-specific education and training in nursing home care. If we just put any doctor or any nurse practitioner into the building and don't teach them about how to practice in this setting, they are not going to be successful, and they're not going to be be able to help you in your management and improvement. So I think it's really key that we make sure that they too are educated about all of these initiatives and about how to practice in a nursing home. And we'll talk a little bit about the need to know calls, because certainly they need to also know what to be doing when they're called. It's not just that when a nurse is getting all the information together, but the practitioners need to know how to respond. Career focus, really no different than the general population for nursing home residents. We know they're all at some increased risk for the reasons we talked about. But I think simple things you can do, and you can incorporate this into your daily routine in the facility. Just ask yourself the question after you've completed an assessment: would you be surprised if this patient became septic during the next day, week? And if not, you should really be having that patient potentially on the work charting, so that you're keeping a very close eye on what's happening with them, and looking very closely, especially for low-grade fever or several changes in mental status, so that you can identify those condition changes early before they become septic. Again, for your short-stay patients, they can give you a reliable history. One of the things I often do with patients when I can't figure out what's happening is I basically ask them, do you feel better than when you came in here? And because, again, we maybe have different practitioners seeing the individual day to day. If a patient tells me they're feeling worse than when they came in, that should be a key for me as a practitioner or nurse in the building to really start trying to ask why. So the conditions, we're in a course of illness and post-acute, we're hoping that people are going to improve, and if they're not, we need to be asking questions and ask them quickly. So are they on that path of improvement? If not, we've got to investigate why not. Okay. So other things, but who else? Who are your high-risk folks? Anybody who's got a line in, anybody who's got a Foley in. And some of you have got vents and trays. And certainly, anytime we penetrate, if you will, a host defense mechanism in any way, we're putting somebody at higher risk for infection. So any indwelling device, and more people are coming with all sorts of things to the post-acute setting, all of those are going to put people at risk. Particularly what I say, if it's something that's supposed to be draining, and the draining stops, and it's not because there's no more, if you will, stuff to be drained, it's often because there's a blockage, and that's when somebody's going to be at higher risk for infection. When infected material drains, a good example is Foley. You usually don't get infected with a Foley catheter until there's some degree of obstruction in that catheter. So, again, whenever there's a sudden decrease in drainage, you need to make sure that there's not a blockage that then puts the patient at further risk. If a patient has been in the ICU, first of all, there's a good chance they're going to be colonized with drug-resistant organisms because of their ICU exposure. And likewise, those patients are basically sicker. We know that those are patients that when they come to nursing homes tend to have longer length of stay and are much more complicated and stay longer. So again, patients who've been in the ICU in their prior hospital stay or folks that may certainly be at higher risk for sepsis admissions certainly be on their radar screen. Post-operatively, and I know the electives, the hips, the knees, which we see very few of these days anymore, most of them are going home, but we still see some, particularly if they've had a post-operative complication. But those are folks that also have risk. Usually our elective procedures are not that risky, because frankly you're not doing elective procedures on high-risk patients. Frequently you're going to either have already managed that risk prior to the procedure, or you're not going to select that patient for having a procedure. So it's usually your patients who've had the urgent and emergent patients. And I would say, from a surgical perspective, that's usually what I would call your dirty butt cases, your perf, anybody who's had that is now in your facility. Other types of things that patients have a history of splenectomy, do not forget that patients remain as high risk for infection down the road. Okay. So we have cancer patients. So if they've had recent chemotherapy or risk of becoming leukemic at some point, they may be at higher risk. And we know that tumors that obstruct, again, the same principles we talked about with the drain, when things are obstructed, they don't drain normally, and therefore we put somebody at higher risk for infection. So obstructing lung tumor is going to put somebody at higher risk for developing a post-obstructive pneumonia. So those are all things that we should be thinking about when we look at our patients. So who else? We do our diabetics, risk for all sorts of things, particularly if they're uncontrolled. And certainly, on the other hand, if we start having someone who's in control and then lose control of their blood sugar, we should be looking as to why, and not uncommonly it can be an infection as the underlying cause. So a diabetic whose blood sugar has been controlled and now becoming uncontrolled, we should begin to monitor them more closely and see what's actually happening and why they're losing control of their diabetes. We talked before about medications, the risk of swallowing problems with potential aspiration and pneumonia. Individuals with pressure ulcers, if we don't treat them appropriately, they can certainly become infected. Vascular wounds, particularly if we're unable to revascularize the patient, frequently are going to eventually become infected. So we also know patients who've already had an episode of infection are at higher risk for relapsing and having another bout of infection. So we need to watch those folks closely. Sometimes I'm not sure that, we kind of do 24 hours and they're fine, so 8 bed rest for 24 hours, they can go. But I think we need to keep a very close eye on any patients who've had a recent infection. And obviously patients who are on treatment and aren't getting better because we're either haven't identified correctly what's going on, we don't have the right medications in place. Diagnosis patients notoriously are at higher risk for infections, not just site infections from their access, but also because of their end-stage renal disease. It puts them at immunity is not as good. Your HIV/AIDS patients with low CD4 count, any patient who really has neutropenia from any cause, could be medication related. So certainly those are also, we should really be concerned about their risk for infection. So a lot of this is all about anticipating. I kind of made this up and thinking about what we need to do. We need to be ahead of the game in post-acute care. We want to avoid the sepsis. We want to prevent the patient from having to go back after the hospital. And so these are some of the things that we can go through that will either trigger us that we might have a problem or give us some guidance on what we need to do. Other things, your morning stand-up. Maybe it shouldn't be just Monday through Friday. It should be every day of the week, when you really are critically looking at your high-risk patients. When you're meeting with your medical director, true at-risk rounds, so you're really looking at the patients you're concerned about. Somebody who's just not right. You might need some additional help with, or your practitioners you don't feel are responding appropriately to the changes that are reported then. You should always be looking at all your transfers to go out because you'll identify missed opportunities, and that time maybe you'll get it right, or get it better. Antibiotic stewardship is key, actually, to the reducing sepsis. You need to be using the correct medication. You need to have the right antibiotics in-house. Work with your consultant pharmacist on this, and the pharmacists are doing a lot of antibiotic stewardship. And I would consider one of the things that we've developed is that all first dose of antibiotics should be considered stat. If I've made the decision that someone has an infection, a bacterial infection, I think they need to be treated. In most cases, they need to be treated now. If it could wait 12 hours from now, maybe it's not really warranting treatment, or I could be waiting for culture results or all sorts of things. But I think the real key is that when I've made a decision that someone has an infection or wants treatment, that we should get those antibiotics in the patient as quickly as possible, not necessarily wait for the next medication cycle. I think it's important that you track your performance and that you use SOPI, the new second regulations that are certainly out there, to track your performance and see how you're doing regarding infections. Look at your sepsis rate, how many patients are going out with infections, and can you improve that? And I think the other thing is working with your area hospitals to share data, education, training, and best practices. You need to know their infection issues, and they shouldn't be hiding that from you. If your area hospitals have a problem with C. diff or have a problem with drug-resistant organisms, you should make sure that you know that so that you're able to adjust your response to those patients when they're coming into your facility. So again, I really encourage that you work with your area hospitals and that they be expected to share data with you and you share data with them. And I think in doing that, you'll have a win-win and be able to focus on decreasing readmission. Just a couple comments about the final regulations that have been just came out. Administration, really what we're going to be asked to do is to staff, educate, and train based on the scope of care that we're providing in our facilities. And I think that's going to be very unique for most nursing homes. The issue is see how that works out over time. I think in terms of infection control, there will be requirements, although I think they stayed with that for a while, for having dedicated infection, at the time it's going to be the infection prevention control program, and includes actually an infection preventionist in our facility. Okay. So just in summary, I think all the things that we've talked about, it's hard to recognize sometimes in managing this setting. It's a common cause for hospitalization. We've got to be on top of it early. We must think, we must anticipate, we must practice. And many of the current infection-related initiatives that are available actually are related and can help support each other. And we need to engage our medical directors and practitioners in these initiatives. So with that, Sandy?
Okay. We'll take questions at the end. So here we are. Where do you start? We're all at risk. where do we start in a long-term care setting? And I think the bottom line is that we have to accept the fact that everyone in our facility has some level of risk for sepsis. So that means we have to start in the first place, which is training. We need to raise sepsis awareness in the organization and keep it front and center. In my mind, it should be right up there with the fall risk assessment and the skin assessment. We do a sepsis risk assessment as part of what we do every day. When you look at the fact that everybody in your facility is at risk, and when you think in Maryland and Virginia, how many of our residents are going into the hospitals and how many of them are dying, we need to make sepsis awareness front and center. So how do we do that? I think it needs to be part of new employee orientation. And it needs to be an annual core competency of all your nursing staff. There are also a lot of visual aids you can put around the facility to help raise that awareness. And I'm going to go through many of the tools that we have as part of the Maryland Stopping Sepsis in Long-Term Care. We have a core of programs called Seeing Sepsis 100. I'm going to go through these rather quickly because most of the Maryland facilities are aware of these, and the Virginia facilities will get these if you join the program. But the Seeing Sepsis 100 card, I think, is an excellent tool that can be utilized by all your staff, especially your GNAs. These are cards, and I'm going to show you the way it comes to you is in a 8.5 by 11 sheet. They're all separated, but these cards can be put in the pocket of staff. They can be posted, enlarged, and posted in places, and it's simple stuff to keep in mind. Temperature above 100, pulse rate above 100, systolic blood pressure below 100, and does the resident not look right, act right, feel right? And I'll stop here and say everything I've read and every presentation I've seen recently, changes in that resident's baseline condition is probably the first signal something's happening. No, it doesn't always mean it's sepsis, but it does mean something's happening. And if we look a little deeper, we can often find what's going on. Just to know, a couple of the facilities that are participating in Maryland, one of them has actually laminated these cards and gives them out in orientation. Another one has made them part of the name badge, so it's like the back of a name badge. Some things people have done. This is another one of the tools, and this is the skilled nursing facility sepsis algorithm. Some of the facilities have liked this a lot because it walks you through step-by-step what to do. It is more geared towards nursing, and it is something you could use as you educate the staff. It's also something that could be posted in a nursing station. And it goes down to when you notify the provider. But to hit on something Dr. Levy mentioned, and it's in this as well, you need to know a resident's wishes way far in advance. We need to not be sending people to the acute hospital who don't want to be there. We need to know when we're providing palliative care, comfort measures, and or treating in the facility. This is the next tool, the AGSF poster. I think is an excellent poster that you can post on, again, in the nurses' stations and the break rooms. And some facilities told me they actually put them on their med cards. And what I like about it is, one, is it really emphasizes to people the importance of every hour that's wasted. It also has your Seeing Sepsis 100 cues there, your temp, your heart rate, your blood pressure, but it also has the nursing assessment on the left side. We prepared a PowerPoint presentation for staff training that includes talking points and takes that nursing assessment apart into pieces to help you with training. And that's available at our online community. You just go on and you can have that PowerPoint. This is the Seeing Sepsis 100 resident care, and this is really for severe sepsis and septic shock. It, again, does give you some outcomes and specific steps to take, and whether or not you would be using the, starting one of the bundles. In most cases, these residents in severe sepsis and septic shock should be in an acute hospital, unless you have a higher level of care unit. So now we've got all this, we have to do generalized training, but what comes next? And again, mentioned this before, you need to know your residents. If you know your residents' baseline cognitive and functional capabilities, you're in a position then to understand the subtle changes that may occur, and of course the wishes for treatment. Then that's one of the first signals that we have that something is happening. And you want to think about the four major infection sources. You have a change in behavior, mentation, or functional capabilities, and you think lung, skin, urine, gut. Something going on. Wounds, lines, catheters, UTI, C. diff, any of those possibilities for infection. This is an example from Interact, and they have some excellent tools. They have a changing condition. When do you report something, and when is it immediate, and when is it when is it non-immediate? Sorry about that. They also have the stop and watch, and I'm sure you're familiar with it, but look at what it says. Seems different than usual. Talks or communicates less. Overall needs more help. What are we talking about? Change in condition, change in functional status. We need to be on top of that. This comes down to the communication, and this is a sample of an SCAR communication tool for sepsis. There are lots of other examples out there, and we're giving you just a few of them. There are many more that you can find, but this one gives you what's the information you need to gather before you communicate to the physician. Here, this is what the assessment needs to be. What are the things that you need to do to assess for possible sepsis? And the last part, what are the recommendations? And when you're a nurse and you're contacting the physician, you need to make some recommendations. Tell them give them the information and tell them what you're concerned about. If you're concerned that there's possible sepsis, that should be communicated to the physician. The other thing, where do you start with new admissions? And we need to screen new admissions for that infection. Current or history of it while we're in the acute hospital. And so we just had a history of sepsis and a prior hospital admission. Once you've had sepsis, you are always more prone to get it. You know, the lines, we talked about that before, the procedures, and getting that clear picture of the person's mental status and capabilities. Can they do their ADL? What are their verbal skills? Because if you see a decline in that new admission over 24 hours or so, there's something going on. And then when you think about it, how many of the returns to the acute hospital are not occur in that first 72 hours? So you want to develop some criteria for identifying your residents who are at risk. Obviously, you can place all new residents who trigger one or more of your criteria on a high-risk rounding tool. You've got Interact, Stop, and Watch. You can look at new infections, but you want to utilize a high-risk rounding tool in order to monitor changes and be prepared to do a quick nursing assessment if a change occurs. And acting quickly is really important. One of the things that I saw at a recent seminar was time is tissue. You want to teach staff time is tissue. If you waste time, you can lose that resident. Here's an example of a new admission screening form. Again, it's just an example. It gives you some of the things that you would screen your new admission for. And you come up with a system so you can score it. You can simply do a check, and then the number of checks can help you decide somebody goes on the high-risk screening form. You can even write some notes. And this is just a little bit more of that same form of some of the things you would be looking for. And I think you saw a lot of these with Dr. Levy's presentation. This is a high-risk rounding form, and we have it courtesy of Genesis Glen Valley. They utilize this to round daily, sometimes twice daily, with nursing leadership. And again, you're using the criteria, you've got your screening, you've got your tools, your residents that maybe just is acting a little bit different today. They go on the high-risk rounding, and you write the reason why. And people can come on and go off of it. That's an excellent tool, simple tool that you can utilize. It's another example of how you can identify the risk. And here you put your resident at risk, why they're at risk, and these are two examples, a new admission and a new UTI and current resident. What's your intervention? For your new admission, you want to document the baseline. You decide you want to round daily or once a week because there was something in that assessment that triggered. Maybe the existing resident has a new UTI. What's your intervention? You want to monitor the urine output because if that is possible obstruction, can end up with them getting an infection. You look at their vital signs, you monitor their labs. Maybe this is somebody you look at twice a day until they're no longer infected. And this, again, is just an example from some stuff that we saw. Bottom line is, in summary, the most important thing, early recognition, early intervention increases survival. And partner with your acute care hospitals. I know Dr. Levy mentioned that, and I'm going to mention it again, that collaboration, communication, and sharing, additional opportunities for learning. Excellent way to really increase the survival of our residents. Make sepsis a standing agenda item at your meeting. Just as you want to make sepsis awareness a part of daily life, make it part of your meeting. Share the data with the medical staff. Share the data at quality infection control meetings and at your nurse staffing meetings. The nurses need to know what these results are. I want to make sure you know where you can access material. This is HQI's online community. You can go in here and you will see one of these little boxes down here where you see cardiac care transitions. A little further down will be stopping sepsis and long-term care. You can go into that. A lot of these tools are available there, as well as within a couple of weeks, this educational webinar will be available there. You can also connect with us through Twitter and Facebook. And we now are going to open this up for questions. Sherry, can you open it up?
Thank you. We'll now begin the question and answer session. If you would like to ask a question, please press star and then 1 on your touch-tone phone. You can remove yourself from the queue by pressing the pound or hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing any numbers. Once again, to ask a question, please press star and then 1 on your touch-tone phone. Standing by for questions.
Sherry, can I also mention, can we also open up the evaluation for people?
I will leave that to Emily on that side. We have a couple questions in queue.
Okay.
Our first question is from Rosemary Kurtz from Laurel Woods.
Hi, I wanted to know how we could, I think you said that the tools are available online. Do you have to be part of the study in order to get those tools, or can we just access those tools for our centers?
I think if you have signed up to the online community, and you have to be a part of the online community, are you in the Nursing Home Improvement Network in Virginia?
I'm in Maryland.
Maryland?
Yeah, I'm part of the CDIF initiative, but...
Okay, well then you're in the Nursing Home Improvement Network, so you should be able to get to these tools, yes.
Wonderful.
You just have to go to the online community. You'll have to join the community, which is just, putting in your name, and then you can go right in and get the information. Wonderful. If you have any questions or concerns, any problems, email me. My email address is at the front of the webinar.
Okay, great. Thank you.
Okay.
And then as a reminder, if you'd like to ask a question, press star and then 1 on your touch-tone phone. And then our next question is from Kendra Cooper from Riverside Health.
Hi, great presentation, and thank you for all the information and resources. We have nursing facilities as well as acute care hospitals, and are working to strengthen our relationship between the two, and as it relates to sepsis specifically. So my question is if you know of any sort of databases that better assist in knowing from a, if they came in from a nursing home, what is their admission source, if you will. So we kind of struggle with that without doing manual audits of saying for these 30 patients that qualify for the sepsis measure from an inpatient perspective, where did they come from, unless we did it manually.
I think, so what you're struggling with is you're on the acute care side?
Well, I'm assistant director for quality, but from an acute perspective, yes, we're struggling with being able to, without manually looking in the charts, to see where they came from.
You'll need to work with your IS people, because we've had these similar struggles, is they're going to have to figure out how to, put in your identifiers when patients come in if they're a nursing home patient. So your electronic health records, you're going to have to figure out a way to have your electronic health records actually capture that at the time of admission. It could be by address from the facilities that are in the catchment area. But I will tell you that is a problem, because sometimes all you've got is an address and you don't realize that the address is a nursing home.
Right. Yeah, and how consistently people put the admission source or the address or something. Okay.
So I would talk with your informatics people and tell them what your problem is. There are probably ways that they can work to help you so that you can track not only nursing homes overall, but specific nursing homes in terms of where the patients are coming from, which is really key, because without good data, you don't know where to focus. So you don't know what nursing home, if you have a nursing home in your area that's having a problem, you don't know who to reach out to. Anecdotally, you might go to your ER nurses, and they may be able to tell you, but you really do need that data, and then also that data to be able to train your, to be able to see, okay, we're working together, are we improving this? Sorry, it is a problem about not knowing where patients come from.
Right. Well, thanks again for all the resources. Very helpful.
Okay.
And then at this time, I'm sure no additional questions.
Okay, we'll just ask that those of you on the line to please complete the evaluation. It helps us to develop the next program that we offer. Thank you very much for your time and attendance today, and look forward to speaking with you again. Goodbye.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.